Good afternoon, everyone. I am Keshav Singh, representing Patient Academy for Innovation and Research. I hope you are all doing well. On behalf of Dakshini and Amravati Health Education and Patient Academy for Innovation and Research, I would like to welcome you to today's webinar on diagnostic safety in the era of digitalization. Thank you for joining us. As you know, every year on 17 September, the World Health Organization commemorates World Patient Safety Day, highlighting the different themes annually, and there is several activities all over the world happening from the date of announcement. This year the theme is improving diagnostic for the patient safety. Pair Academy along with Patient for Patient Safety Network Asia Pacific and Dakshama Health have planned a series of 6 webinars around this theme. This is the fifth webinar which we are in, which themes diagnostic safety in the era of digitalization. Diagnostic safety encompasses a broad scope of concern, as approximately 70% of clinic decisions are informed by laboratory results. Gaining perspective from laboratories, nursing specialists, and patient organization can offer new insights into ensuring quality standards and accreditation. So I would like to invite Dr. Ratna Devi. Can we have the slide, please? The introductory slide. Next slide, please. Yeah, so Dr. Ratna Devi is a medical graduate with a master's in business administration and has a deep passion about health system strengthening. Dr. Ratna is director of Pair Academy, Patient Academy for Innovation and Research, and CEO of Dakshini and Amravati Health Education. Over to you, ma'am. Thank you.
Thank you, Keshav, for that kind introduction. And Keshav has already set the context on why we are having this webinar today. So today's topics will be on how digitization has either enhanced or brought in newer challenges for diagnostic safety. And we do know that with the experience of COVID, digitization has been accepted into the system. Telemedicine, telehealth, etc., and telediagnostics have become more household than it was prior to the COVID era. And people have accepted that, distance diagnostics or people not sitting across the table with the doctor is an acceptable form. However, there is still a lot of hesitancy in this particular area. And since we are speaking from the context of patient safety, not just the operability of having diagnostics from a remote location, how do we actually build the trust, and what is it that can be done to improve that trust? Also, how is data used? What can data be there for either enhancing the supportive function to diagnostics as you would do in a hospital, or when you are doing it remotely, is it more detrimental? Are there possibilities for having problems with accuracy? These are some of the topics that we would like to discuss today. And Vikas, if we can have the agenda displays, please. So I'll quickly run the audience through the agenda. We have 3 wonderful speakers today. Our first speaker will be speaking about accuracy and safety of digital diagnostic platforms, and he is Dr. Netiraj Gandhi. I will hand over to Keshav to introduce the 3 speakers. Our second speaker will be speaking on information accuracy and health literacy through digital technology. And our speaker for this topic is Dr. Suhina Singh. Our third topic is diagnostic safety and virtual consultation, about telediagnosis in particular. And our speaker for this topic is Mr. Nitin Guru. So Keshav, if you could quickly introduce our speakers, and then we can go to our first speaker, Dr. Gandhi.
Can we have a slide? Yeah, second slide.
Third.
Yeah. So I would like to invite Dr. Nitiraj Gandhi. I would like to welcome him. He is a co-chair of HIMSS India chapter, achieved 4x growth in healthcare deal with private equity collaboration. He has impacted 1.2 million lives through startup monitoring and expertise. He is co-contributor to a prestigious Sir H.N. Reliance Foundation Hospital. We are honored to welcome you, sir. Can we have the next slide, please? Then I would like to welcome Dr. Suhina Singh. Suhina Singh is a co-founder and CEO of Jonda Health, a technology company in healthcare focused on revolutionizing health data management with AI-driven solution. With over 15 years of experience in healthcare, Suhina combines her expertise on both a physician and a patient to address the challenges of data fragmentation. We are honored to have you here, ma'am. Can we have the next slide, please? Then I would like to welcome Mr. Nitin Guru. Nitin is a digital health leader with 20 plus year of experience. He is established data and analytics center of excellence for business enhancement. We are honored to have you here, sir. Thank you so much. And then I would like to invite Dr. Nitiraj Gandhi for his first, speaker slot.
And thanks so much, Keshav, and thanks, Dr. Ratnaditi. It's always been a pleasure to be, working with PAIR and coming for these webinars. Just one correction. So, co-chair HIMSS India chapter, Public Health Committee. That would be the right thing, but I understand. Yeah. So, we'll start off with, importance of accuracy in digital diagnostics. I think if we were to look at two parts of this accuracy, first is what kind of systems are we using to ensure accuracy? And across labs, across multiple startups that are indulging in diagnostics. And these startups are coming, it would say, every day you hear about a new startup. And all that they are battling with is how can I get more customers? Now, this haste sometimes leads to a lack of proper platform for technology. When it comes to advanced labs, they have an idea how to process 100,000 samples a day also if required. But when it comes to startups, sometimes they believe that, let me get an n number of customers and then we look at the right platform. And that is where sometimes technology, or a lack of focus on technology can lead to or impacting diagnostic accuracy. It could be as simple as identify, missing out in identifying the right patient, or missing out in identifying the right test, or the vacutainer which is used for a particular patient and a test. Now these things also could be missed out. So that's the first part of the tech platform, and also all the tools that are required. The second part of accuracy is how trained are the phlebotomists. And don't get me wrong, but with the advent of home sample collection, probably the number of phlebotomists we have has gone up by 3x or 4x in India. And how many of these are actually trained? How many can serve a bedridden patient or somebody who's not got a very healthy body weight, which makes locating the vein very difficult. It's questionable how well they are trained, how whether they are all trained uniformly, whether all SOPs are getting followed, and that also in fact can impact diagnostic accuracy. So these are the two parts, fundamentally which can go wrong. Now the third part where accuracy is getting impacted is, so I've been mentoring startups in these areas also for quite a bit of time. And with new individuals coming into the foray who may or may not have adequate healthcare experience, what you see is they understand a lot of analytics, they understand big data, they try and make use of algorithms or try and develop algorithms, but the sample size sometimes is not good enough. So, with startups and with some of the platforms that I've seen is they quickly jump onto a judgment that since this worked for my past 400 patients, I've got a 400, 500 patient data, I should go ahead. This will be relatively error free. And that is where you actually get blindsided, because maybe one algorithm works, the second one works. But when something goes wrong, you're not giving yourself the opportunity to test, to calibrate, to rework on your algorithm, to address any errors and take the right help. So, that's one of the most important factors where they lack mentoring, or probably, there are valuations and other things to be chased. So sometimes the mentoring also gets ignored. So how do you address that? I think is most important. And, given the auspices of creditable organization like PAIR, if we were to come together, have a platform where there are let's say a bunch of mentors who can work with these startups, who can work with multiple such companies, and make them aware as well as vigilant about some of these errors that can creep in, which can be potentially detrimental to the patients and their own reputation. I think that's how we can work towards diagnostic accuracy. Now, if we were to look at, this is more B2C side. If I were to look at the provider side, so some of the factors that are affecting diagnostic accuracy on the provider side are, how well are they managing their master data? That's very important. Now, if my name is Nitiraj and somebody spelled it out or wrote it Neetiraj in a hospital information system, then essentially you will not have my medical history if another name was used, another spelling is used. Now, if a pathologist or somebody who's heading the lab is not aware of my previous results and there is a sample mismatch, there is a test mismatch, that could lead to potentially very grave errors. And that's where the tech needs to be foolproof, or you have to move towards standardization where you're doing deduplication, you're standardizing all of the names that you capture, standardizing the UHIDs, and thereby giving the doctor as well as your own algorithms a complete picture that probably a person had an HbA1c of 8. And now, if the tests are showing that the HbA1c is just 6, whether it is right or not, or do I need to do a redo? Do I need to speak to the doctor? Do I need to speak to an endocrinologist before I publish this result? Or is simply a redo going to matter? So these are some of the finer elements in diagnostic accuracy, and I think communication, mentoring, and right data as well as tech management, these would be the three correct pillars around which we can build it. Now, one of the important elements was quality of data input. Now, how do I ensure that there is a quality in data input? I work for a firm where we do a lot of patient engagement programs. And one of the challenges that I've found out is when we are engaging with patients for their diseases, or for, any long-term care that they are on, let's say rehabilitation post-surgery or other things, we see that the mobile number entered of the patient is sometimes wrong, their email ID is sometimes wrong, or one patient's mobile number, the front office executive has just used that and copy pasted it across all the registrations for the entire day. Now, this could lead to potentially wrong message going to the wrong patient. It gives a very bad impression of the provider to the patients also. It also raises the question whether you are exchanging my data with somebody, which is not the case actually, but you are actually entering bad data. The third bit is, what is the use of having such a mobile number at all? Tomorrow, if in my, I have an Aadhaar card, everyone of us, who are Indian citizens would have an Aadhaar card or a social security ID. If that mobile number of one person, cell phone number of one person is used by 100 people, what good is that, social security ID? There's nothing unique about that identifier. It's always going to be a mismatch. And that's where data input really matters, and training people, making sure that they are also compensated well. I think let's also understand the practicality in India. One of the, and across the world also, front office is one of the functions that is highly ignored. Training is ignored, compensations are ignored in these cases. So you need to have well trained staff there, at least a good amount of supervision, and if possible an interface for the patients themselves where they can validate that this information captured is mine, and they just put a consent, so that at all times you have all of these records, and the patients are also aware that, why am I getting a particular message, why am I getting certain communication, what does the doctor know about me, what kind of data exists in the hospital. That's how we are going to improve everything, not just the diagnostics, but the overall healthcare of this country. uh, the next part, I'd like to speak about is how do you develop and validate these or algorithms. I'll take you back to probably 6 years ago, and I'd moved from the provider side to consulting, and I met a person who had done a supply chain based algorithm. So he could predict that for a hospital of X beds, if these are the specialties, then typically what would be the total inventory size he requires, what could be the subspecialties by in which what inventory needs to be factored in. Now, when we were discussing about consumer health, and especially just before COVID times, and we were going through some of the algorithms where we are saying that there are algorithms for predicting potential cardiovascular diseases risk, diabetes risks and all. And there came a casual statement. This is an individual with 15, 16 years of experience coming through with a casual statement that if I get 100 patients data, I can do a better algorithm than that. And my first reaction to it was, yes, you're doing consulting, but the first thing that I want to do is I can't work with you. And the only reason I can't work with you is because you do not understand the seriousness and the difference between supply chain versus a human body. And I cannot allow you to experiment, no matter what kind of algorithms you want to build. And somewhere, I think, as individuals, as mentors, we need to take a very hard stand. I think we ignore, some online platform offered a test, the test went wrong, and we say, okay, it's a part and parcel. They're doing it for so cheap, it's so convenient. So sometimes it happens, and that's where if you can put your foot down and say that no, this is not acceptable, I think that will allow us to help them to build better algorithms, to validate those algorithms. And there's no better validation than a customer and a person who's got some decent degree of healthcare knowledge giving you input that what you're doing is right or wrong. I think that's very important. Some of the good examples of AI driven diagnostic tools, I think, are available. If you look at purchasing online health insurance in India nowadays, you'll see multiple private healthcare insurers who will take down your age data, previous disease history, history about your parents and other things, and then they'll do some underwriting. Now behind that is an algorithm. I've seen that those algorithms myself. These algorithms were developed for at least 3 to 5 years through great mentoring also with these same companies. If I'm doing a health check for a corporate with 1,000 people, 1,000 employees out there, what could the potential risk for diabetes within this population be? And that's how those cohorts got modified, the algorithms got modified, additional questions were put in, including sleep habits, eating habits, daily exercise routines, which is way beyond just lab parameters, right? And that's what allows you to do the risk stratification, give the individual the confidence that you've spoken to me enough, you've understood what my behavior is, health seeking behavior is, and how I react and how my body is reacting. That's how these are some of the AI driven diagnostic tools that are doing well. In radiology, I've seen, teleradiology being of great help, especially on chest X-rays, diagnosing tuberculosis or some of the artifacts of the lung and other things. Uh, However, it's a bit more simpler, I would say, in radiology, because there are pixels, there are voxels, and it's very identical, and you might be able to do a better accuracy when teleradiology is concerned, and there's an impact of AI. You're using AI along with it. The only thing that we should not get overboard with is, does an artifact that I see in patients in a particular region, does it have to correlate with patients from another region? Okay, there could be nuances, there could be regional nuances, there could be nuances related to race, habits, all of those things. And the normal values will also change basis that. So long as we are cognizant of what we are doing, we are also getting enough inputs from people who have done some hands-on job in diagnostics, who understand healthcare. I think that's when technology becomes safe, technology becomes usable, and there would be great accuracy in digital. So with that, I'll just stop now and hand it back to Keshav. Yeah, Keshav and Dr. Ratna. I think you're on mute.
And you are mute.
Sorry about that. Thank you. And you raise a lot of very, very relevant points. While there is this hope and the sort of futuristic vision of how things will change for healthcare and make access more relevant, especially in hard to reach areas. And there is a lot of discussion in these areas as to how people who are not able to travel, or who do not have access to a specialist, or who are placed in geographic locations where it is difficult for them to access advanced healthcare, digital can be the solution. But then, to be a relevant solution, there are so many boxes that need to be ticked. And one of the things that you raised was having patients validate that data themselves. And that brings us to our next speaker, who's done a lot of work in this particular area. Dr. Singh is herself, a patient with lived experience. She believes strongly in using data, especially with patients themselves, inputting into the quality to advance healthcare. So, would love to hear her thoughts on this. And she also runs a data-driven company. So, Dr. Singh, over to you for your presentation.
Thank you. Thank you, Dr. Ratna. So really absolute pleasure to be here. So thank you so much for having me. Can I just check, Keshav, do you want me to share the slides or you're going to share it on your side? Happy either way.
Can share, I think. Here it is.
Fantastic. Thank you so much. Great.
Thank you.
So let's move to the next slide because Dr. Ratna did such a great job of explaining what we're going to be talking about. So this is me, CEO and co-founder of Janda Health. I always love to connect with everyone, so feel free to connect with me. And I really want to go on to the next slide because I don't want to waste time talking about myself, but I really do want to share my story, right? And Dr. Ratna knows the story very well, but for those of you who obviously don't know me, I have 3 autoimmune disorders. Thankfully, they're now all in remission. But for the longest time, I suffered quite extensively. I actually had ankylosing spondylitis, which is an autoimmune condition that affects the spine. And I was in so much pain. I went from doctor to doctor to doctor to doctor. And it took me about 7 years of suffering to really get a diagnosis. And, it's very frustrating when you're a physician yourself, and then you're put in this position of being patient. You keep telling people there's something wrong with me. I'm in pain, and you're really trying to figure it out, right? I mean, it's incredibly frustrating. And in so many ways, I think you feel really helpless. And it's not for the lack of testing, right? I had so many tests done over the past 7 years before I really got to a diagnosis. And the sad thing is that it's not that the data didn't exist for people to actually know and point them into the direction that, hey, Sahina has most likely ankylosing spondylitis. And the reason is not because the data didn't exist, which is great, right? So the data exists, which is amazing. The challenge is the data was scattered all over the place, right? Every different doctor had different pieces of the information. No one had a complete picture. And so that's really what contributed as well to that 7 years of really getting a diagnosis and saying, hey, this is what's wrong with me. This is what we need to do. And the reason for that is a word that maybe you've come across, maybe you haven't come across it. And that word is the word called interoperability. And interoperability is the ability for systems to be able to take in data and then actually be able to use it, right? And using it means being able to do something meaningful with it. So maybe I can ask you to switch to the next slide because I want to share with you why interoperability really is an issue. So it's pretty much like I said with regards to different systems. So if you look on the slide, you can see there's different power adapters, right? And all our data is power, which is amazing. We can do all these amazing things. Yeah, but we need to be able to use it, right? So if we can't use it, that's a problem, right? And it's really scary fact for me is that like, look, 30% of the world's data is health data and 80% of it we can't use. And like, as we increase with digitization and efforts, all these IoTs and stuff, it's absolutely incredible. Yeah, but we need to be able to use it. We need to be able to access and actually use it, right? And many times this is not the case, right? So why do we land up with all these different adapters? So next slide. So this is why. Because every healthcare system has their own platform, their own standards, and then like even different privacy controls, right? So if we look on the right-hand side, you can see that we're dealing with different standards, different transport standards, different content standards, different terminology standards. And by the way, in emerging markets, guess what? You have people who also have custom standards, right? And then people could be using different versions of different things, right? So if you just look at that alone, right? If you do the math, you're looking at probably over 22,000 different combinations that maybe exist in the world, right? And don't forget, we also have languages, right? And so even if we look at something as simple as a white blood cell, right? There's, by the way, over 28, 30 different variations just in the English language to how you can call a white blood cell, right? Which is great. And actually every day we keep learning more, which is amazing, which is why I love what we do. But the other thing is that there's so many different units of measurement that one can use, right? And part of this is because, look, different labs, and by the way, even sometimes in the same lab, they can have different machines doing the same test, depending on how that lab is set up. And so you may have different units of measurement. All the systems basically have expressed the different units of measurement differently. So you can see here a study done by the CDC, and you have 58 different unit strings for routine white blood cell counts, right? And the funny thing is that 58 is a lot less than what we come across. And by the way, this is only for the English language. So when we're really trying to leverage data, I'm sorry, but as much as we'd love a system to know that, like, this is equal to that, yeah, it's going to look at this as 58 different things, right? And that's a problem. You are trying to use the data. So maybe next slide. So I think it doesn't matter where we fall in the ecosystem, right? It's completely inefficient. We'll end up with a bunch of inaccuracies. And at the end of the day, we're just really not taking healthcare forward. Next slide. And so I would say that, like, it doesn't matter whether you're, next slide. All right, so it doesn't really matter where you sit in the ecosystem, we're all negatively impacted, right? For me as a patient, I've already told you my story. It took me 7 years to get diagnosed. I'll share another story with you, and that's because of the application that we have, and I'll share it in a bit, that I was actually able to realize, hey, I had an iron deficiency, right? And I was actually able to call the doctor and say, hey, I have an iron deficiency, or I think I do. And I was able to get things sorted. And that's the beauty of actually having data that's actually usable. And I'll show you how we go about doing that, right? And I would say as a doctor itself, when I was practicing in the field of oncology and cancer medicine, you have patients coming to you and they're seeing different specialists or seeing different GPs. You don't have all the data. And you spend like 15 minutes, 20 minutes trying to get the information, or you're repeating unnecessary tests when actually the data already exists. And the person that's worse off is the patient at the end of the day, which for me is completely unacceptable. And then if we really want to be doing really cool things with research and really trying to figure out new ways, well, once again, the data needs to be usable. I was speaking to one of the healthcare clusters here in Singapore. You know what? They're responsible for creating all these wonderful like algorithms and AIs. But they spend 80% of the time just trying to make the data usable and 20% of the time in actually creating the model, right? Crazy. It should be the other way around, right? And if we look at COVID-19, when we look at broader health systems, once again, COVID, there's, like I said, there's so many different ways of naming a white blood cell. It's no different for COVID-19. Lots of different ways of naming COVID-19. Fun fact, in Indonesia, for example, COVID-19, I think, is not in the ICD-10 coding that they're using. So they classify all of the COVID-19 as the ICD-10 code for influenza. So great stuff. Okay, next slide, please. All right, so what we did was, what we realized in a lot of cases is the data is not coming in. And in many cases, you're dealing with like an image or a PDF. So labs, for example, when labs are sending the data to like doctors, they're either sending it through a system and it's a PDF and that's it. It's a PDF, or there's a printed copy that goes to the doctor, or even these days, it's still coming via email or whatever else. The data is still stuck in a PDF and everyone's like, yeah, it's a digital file, it's digitized, great. Tell me, how do you use the data from a PDF? Because you actually can't, right? It's actually not, in its true sense, digital data per se, right? And in many times also, you're just dealing with images. So what we decided to do was create what we call a travel adapter. So an adapter translator. So as you saw, like different plug outlets, and we really act as that middle adapter in between. So it really doesn't matter what an individual system is. They just need to tell us what data they can consume, what is the names that they like to call things, and they can throw anything in, and they will always get a file that they can actually ingest into the system, and then they can do all the wonderful things that they want to do when it comes to data analytics, AI, risk scoring, whatever they want to do. So actually, we start to actually remove the constraints around the usage of data. And can I ask you to switch to the next slide? All right, so what we've done on the patient side, and actually this is how we actually started, but John Direct is actually deployed behind a patient-facing application. And the reason why this was so important was, like, I was carrying around like a bunch, literally a big red box full of files. I couldn't find anything. And in between, it was great that I got a diagnosis, by the way, but in between trying to manage my own data or what's happening with myself amongst 5 different specialists, even as a physician, I struggled, right? So, like, I think if I struggled as a physician and I've studied X number of years, have so much of experience, now what is a normal patient supposed to do, right? So some of the cool things that, like, we did with Jonda, the app, is that we allow the patient to literally take a photo or upload their data. What we do if it's a blood biomarker test is that we do exactly what you saw in the previous slide. We standardize it and it's graphed so that actually patients can start to see what's going on. And that's part of the reason why I figured out that I had an iron deficiency, because I felt really tired. And then the next thing that came to mind was like, oh, I wonder what's happening with my iron. Went on the app and I was like, oh, a beautiful curve downwards, trended data, I can tell straight away, and managed to actually land up with an IV Venifer infusion. So an iron infusion, for those of you that don't know, with the GB, fantastic. It was the most seamless way ever that I've been able to sort of sort out my own health. And I'm like, this is amazing. And I think the other important thing is that, like, sometimes as physicians, we expect we expect patients to sort of know what certain things are. But you know what? A white blood cell, WBC, a patient does not know the same thing is equal to that, right? So what we did is we enabled smart search. So a patient can search for what they know, and they will always find it because we're using the language the patient knows, right? Using the terms that they use. So even if they're trying to search for something like blood test, March 2024, something super simple, at least the patient's not going to call a blood test or my hematology test, my UNE. And if they want to, they'll still find it. But it's really about using language commonly and really, like, enabling the patient to find things in the language that they know. And I think the other important part is also really respecting privacy, right? So we're one of the very few applications that I know of that uses something called zero knowledge encryption. And so what that means is that we can never use the data without the consent of the patient, to the extreme that actually the encryption, part of the encryption key is what the user has decided, right? And we use whatever secret phrase that they've created to actually encrypt the data, which is really amazing because that means we can never actually access that data. The only person who can access that data is the patient or whoever the patient has shared that data with. Next slide. Yeah, so I would say that for anyone who really wants to know more about how to make data usable or really help us to sort of unlock data or really make a difference, because I really feel like us not being able to use data is really taking the word care out of healthcare. So if you really want to be part of helping to put care back into healthcare, we're really happy to help. Whether it's a patient-facing application for patients who want to use it, great, go up. If you need anything, let me know. For other people who are really struggling with this problem of making health data usable so we can really drive change, once again, just feel free to reach out to me and I'm really happy to have a chat. Next slide. Yeah, so I'm not sure if we're doing questions now, Dr. Ratna, but I'm really happy to take any questions because I think that there's so much that can be done with the data. There's so many ways we can enhance existing solutions by just making the data usable.
Thank you. Thank you, Dr. Singh. And before I move on to our next speaker, I do have a question. I mean, this all sounds very exciting, but then we do know that in most of the developing countries, the the start or the basis is having no data. Everything is handwritten or sometimes small scraps of paper where you will find this kind of information. Given that situation, will this kind of a platform or this kind of an application still work? I know you said you can just take a picture and upload it, but it'll be a lot of work in many different languages, and doctors' handwritings is not always decipherable or readable. So, will it still work if we say brought this to a country like India and used it in remote populations?
Yeah, so that's actually a great question. So 2 points to that. First of all, we've actually started with blood biomarker data. The reason for that is because 70% of diagnosis and follow-up is actually a blood biomarker. And so as complex as it is, I think it's a low-hanging fruit, because actually if we look today, most like lab data to some degree is actually digitized. I say that, but then a lot of times the data is actually manually encoded into a system. And as you know, when you're transcribing things, we have issues. That's part of the reason why we started there. The question around like handwriting. So I think that like every day we're seeing advancements in like optical character recognition technology. And so even for us, we need to realize like when something is circled or when something is written, what can we do with it? But at the end of the day, honestly, we need to be realistic as well, right? I mean, even as a physician myself, when I was really tired and I was writing things, and even to this day sometimes, I can't even read my own handwriting, and I'm the one that wrote it. So we cannot expect a computer to be able to know what I've written if I don't even myself know what I've written, right? So we also need to be like reasonable with what we expect technology to do, right? Because if we can't read it, then okay, Houston, we have a problem. What we do though, Dr. Ratna, is that we have a human in the loop. And it's really important for us to have a human in the loop, because the system needs to flag errors based on what it knows. And to say, hey, yeah, never seen this before, don't know what this is. This just seems really weird and out of whack for what it should be, that it has to go to a human in the loop, because we're dealing with clinical data. So that the human can go, okay, wait a minute, what is this? And help to train the system. There are cases, though, Dr. Ratna, where even the human cannot make sense of it, because maybe it's such bad quality, it's so blurred, the document, that there is no way of reading that. The only thing we can do is process it as an error, right? So I would say, like, even if you were to zoom it at maximum scale and you still can't see because it's so blur, I mean, so I would say there are these limitations, but I would say let's not let the limitations hold us back from actually making forward progress. So there's always a way, but once again, if a human can't even decipher it, what are you expecting a computer to do when a human can't even see it, right? Not going to happen.
I agree. Yeah, very interesting. So I'll come back to you with a few more questions, but let me invite our next speaker, Mr. Nitin. Just to put things into context, I mean, we are looking at people who already have a lot of data and their data is not readable, to a very large section of the country who do not even have access to a healthcare provider. And Mr. Nitin is doing that wonderful job of providing that access and making it possible for people even in remote areas to access a consultant. So how easy or how difficult it is, given the complexities of say bandwidth or smartphone or language or health literacy, and when you put all these things together, and the fact that we have different systems of medicine and people might be going to multiple systems and multiple doctors, how do you manage that? And what is your sort of perspective on providing these in a way that minimizes errors and minimizes harm to the patient? So over to you.
Thanks, Dr. Ratna. It's always been pleasure to meet you. I think last time we met in a Net Health Summit, and we are meeting now. So again, thanks for hosting me, and glad to be part of this really enlightened panel. I was deeply intrigued by the challenges which Dr. Nitiraj posted and Dr. Suina also mentioned, and would like to share my kind of light towards how we do the diagnostic safety in the area of digitization. Keshav, maybe we can start with the first slide. I think before I jump into the topic, I would like to highlight why diagnostic safety at all is required, and especially shed a light towards India. So, in terms of diagnosis safety, which refers to the safety during the diagnosis, during the recommendation to the patient, uh, just want to highlight that medical errors is the biggest reason of deaths after heart disease and cancer. It is so serious that over 5.2 million patients in India every year impacted by medical errors. So that's where it becomes like really important that we ensure diagnosis safety. But if I talk about Indian context, there is a huge gap in terms of doctors to patient ratio, especially if I talk about specialists like endocrinologists or cardiologists. Like cardiologists, there are only 43,000 cardiologists in India, and endocrinologist ratio is somewhat like that only. So imagine cardiac capital of the world, or diabetes capital of the world, where most of the patients, about 30% of patients, cardiologist patients, are in India, and we are not able to provide them the right kind of care in those kind of cases. How we maintain efficacy, how we maintain the quality which every patient not only desire. I think it is the right of the every patient. So at this moment of time, of course, there are three various options which I would like, Keshav, if you can take it to the night, the next slide. So definitely viable solutions are like we get more doctors, we get more providers, we improve the current maybe medical education, and get more and more doctors become specialized, become qualified to take care of the patients. And interestingly, there has been a lot of development on that regard as well. So government has been opening new colleges. There has, I think now the count of AIMS is 24 in India. So there are a lot of infrastructure which has been developed to get new specialized or new doctors to be trained and then specialized. However, this is a long journey, right? So even for taking a specialization 2+ and then 4, it takes 6 years, right? And that journey we are already in. So I think on that part, government has taken good steps, and we are seeing that that journey has already begun. On infrastructure side, also government have invested a lot, and they are promoting different kind of programs through which private players also are joining hands, and then public health is also developing. But again, doing all these things at the scale where demand is so high, uh, all these development would not be able to suffice if we don't use technology. So whether we understand that there are challenges developing algorithms to meet the need, like Dr. Nitiraj has suggested. The time has come, and I think it is a dire need that we start using technologies as soon as possible to meet the requirement of the patient. And telehealth, or digital health has been the pioneers in helping with this availability gap. So uh, now, if I talk about what we have done in RX1, we have developed a healthcare platform which has two sides. The patient side, we have a patient app through which patient can connect with doctors, and at doctor side, we have a EMR system through which they can analyze the patient data remotely and take the decision which is more actionable, and take the decision which is more data driven. So it is a platform which helps connect patient with doctors, but more and more it is a platform which act as a data exchange between patients and doctor. And when we talk about data exchange, I would like to again do recognize what Dr. Suhina has also highlighted, that there is a lot of different standards being used by different systems. There are a lot of challenges in interoperability, and that's where the kind of solution which we have developed is able to deal with those data complexity, is able to deal with those data challenges, and able to get the latest insight from the data, so care providers can take the decisions. We When we started, we thought about developing a system or algorithm which help patient diagnosis faster. But then soon we realized, as Dr. Niti Raj also highlighted in stock, that doing this basis upon a very small population can be, in fact, detrimental for diagnosis safety. And that's where we recognized it, and we started in a way where we enable doctor with AI solutions, so they can take a diagnostic decision. It's like, again, what Dr. Suhina said, like keeping a human in the loop is really required. And that's where we recognize that and ensured that now doctor has this kind of opportunity to use the medical data in the way which can improve the patient outcomes. Keshav, if you can move to the next slide, please. But saying that, I truly believe that diagnostic safety is not a single side responsibility. We can't just say that medical errors are happening because of doctor's issue. It's always kind of a shared responsibility. For example, imagine you upload a file which is blurry. It's doesn't have right kind of parameter visible of a lab report, and doctors see it. How he's going to use that data? So again, it is a shared responsibility, and it is also responsibility for both patients and doctors to start adopting technologies, because if you don't adopt that technology, um, or only one side adopt the technology, for example, if doctor adopt the technology and patient doesn't, then this is not going to work. It is a handshake, it is a relationship between a care provider and caregiver, which has to go along. Then only we will be able to improve the diagnosis safety and reduce the medical errors. Now, if I talk about what are the key things which we can do as a care providers and patient caregivers, which we have noticed in our journey. So, as a care provider, I think one of the things which we have seen a lot of doctors have recently started doing is encouraging preventive care. And when I say encouraging preventive care, it's like helping patient with those kind of reminders and notifications which help them taking care, taking their health care. For example, in especially on the maternity care, I've seen that the doctors who are now advising patients to take to guide them for food they should take during maternal stage, and exercise, etc. The same goes for patient as well. Like prevention is better than cure. Then as a patient, we can always start taking care of our diet, exercise, and avoid those kind of situation which can end up in a serious trouble. The second thing I would like to highlight, that digital is not only responsibility of again the doctor. So definitely doctors should, or providers should, encourage the digital adoption at their side. But patient also have to become digital aware. And when I say digital aware, so nowadays, if you want to book a movie ticket, you definitely go to Book My Show or any other movie booking website and book a movie ticket. But when you want to visit a doctor or consult a doctor, you end up calling them or end up visiting their uh, hospital or facility. um, it's okay. I mean, when doctor is available, definitely they can see you, but the one need to appreciate their time as well. Many times, what we have observed in our platform also, people book the appointment and don't turn up to the doctors, and you call to the facility and you have booked the appointment, but you don't turn up. That is not a good use of providers time, right? And that is something which I think we need to build a kind of a discipline to us as well, that if we don't appreciate others time, I think we are missing the point. And in the area where there is such a huge gap in availability, it will further become a big problem in future. From doctor side and provider side, what we have seen in India, although the adoption is improving. However, many of providers still prefer manual approach. They still want to write prescription by hand, and challenge here is that however best algorithm we develop, however good OCR system we develop, it will always, there will be room for error. So my suggestion and maybe a humble request to all providers will be that we need to fix that from the end, or input level itself. We need to start generating digital prescription. There are different ways to do it. There are digital pens, there are speech to text, there is way you can simply type, look up, or even create a custom template. But we have to have those digital prescription which are actually digital native, like starting from the input end itself, rather than kind of create in paper and then scan. So that would be my humble request. And the last but not least, when it comes to medical data, a lot of us prefers, when we imagine, like, we are paying electricity bill or telephone bill, we are okay that we get a electronic bill, right? So we are okay with that. But when we go to doctors, we ask for printed prescription, and then we carry it around and go to pharmacy to order medicine, or go to test lab to get the test done. Why can't we have those digital prescription, right? So I think as a medical data fiduciary, or as a medical data owner, a patient itself, I think they need to initiate that. They need to demand that they are okay with digital data, and they should start managing the medical data themselves, in RX1 app, or any other care app which they are fine with, and then host that data, so that data can be shared with the doctors, and from that doctors can start diagnosing using actionable insight. Now there is a very new concept which has started by government India. It's called Ayushman Bharat Digital Mission. Although it's started around 2 years back, but it's really a novel way by which they are trying to do very similar to what they did with UPI, right? So in India, with using UPI, you can pay to anyone using any of your bank account, right? With Ayushman Bharat Digital Mission, what government is trying to do is they want to link your all your medical record, whether you are with avail the facility from any of the hospital, or any of the clinic. They want to link that with Abha ID, Ayushman Bharat Health Account. Using that ID, you no longer need any other phone number or any other kind of ID, but just your Abha ID, and it would be a unique way to share your registration detail. It will be a unique way to share your consent based medical file with any of the provider. So again, my suggestion to all the patients and caregivers would be that is start creating your digital medical records using Abha health account. Again, you can do it in our app or any other alternative app. And once you do that, the benefit of it that you can share these records with your providers, and using that data, providers can take decision which will be highly accurate, and which will help get the care to cure journey faster. So that's all from my side, Keshav. I'm good for questions if we need. Yeah.
Thank you. Thank you, Mr. Nathan, and very interesting. I mean, I do have a personal experience with Abha where it didn't work for me, but I'll come to those questions. I have two participants who wish to speak. So if Dr. Tahira is there, please unmute yourself and ask the question. Dr. Tahira, are you there? So meanwhile, let me move to Pritam. Pritam Sinha, if you wish to ask the question, please unmute yourself and ask the question.
It was a wonderful session from all the person of all the doctors. My question is that as is already cited in the session, we are not medically sound in terms of when we are patients. So, as Mr. Nitin has already told that when it comes to going to uh, not going back to the doctor again and those things are happening, how do you deal with these things? Because, and I'll come to Dr. Suina also, how do you handle those things when patients are not coming back or patients are canceling that? And digital perspective, I have seen, being a patient also, we all are patients somewhere or the other, right? So sometimes we don't want to be go to the doctor and do something in your house, but certain diseases, like in my case being a medical professional, I must say that diseases like orthopedic diseases, orthopedic pain or something like that cannot be resolved in terms of when you are sitting in the house and talking to a doctor. So, is there any digital way or is there any digital perspective wherein that can also be resolved? Sometimes, because I have faced this a very bad issue. I had a very bad leg pain. I could not even come out of the bed to come to the next room also. In that scenario, I cannot go out and visit a doctor. But I have done that online consultation, but I was not happy. He did not even see. He just understood.
Did we lose him? Yeah, I think we got the gist of the question. So if anybody could answer that. Dr. Nithiraj, you were referring to this exact issue. I think maybe you could take this
Yeah,
question.
yeah. Before we got on the call, I think some of these things we discussed. No, and I think patient care is also moving towards the patient perception a lot more than a clinician's judgment. And somewhere there needs to be a fine line with this overwhelming amount of information that everyone has on their mobile phones or cell phones. That if even if you have a stomach ache and you type stomach ache, probably Google will give you n pages of results which cannot be modified by anyone. So somewhere I think that moderation, respecting exactly what condition it could be, why it could be, and the judgment of a specialist. I think those are the more important things. And if judiciously technology can be used, then nothing like it.
Thank you. We also have Carlota who want. Yes, Suina, please go ahead.
Yeah, I just wanted to add to, I think, Dr. Netraj and what he said, right? Because I think also, and I think the doctors can agree with me. I mean, I know when I was practicing medicine, no one taught me how to do a virtual consult. I'm sorry, but it's a very different skill set. Yeah. I mean, how you perform a consult digitally is very different from how you perform a consult in person, right? And so I think that it also goes to looking at how do we also train physicians to be competent as well when it comes to doing that sort of virtual consult, while still making safe diagnoses or safe treatment plans as well, because we don't have all our senses available to us when we're really doing that consult. And I think also, like, medical students today, I'm not really sure if they're really being taught how to deal with that as well. So I think that's also something that needs to be looked at. So I just wanted to add that perspective as well. Thank you, Dr. Ratna, for allowing me to share that.
Yeah, I agree. And, I was actually going to ask you this question because Dr. Gandhi referred to algorithms and Nathan also referred to algorithms. And then you brought this very startling statistics that 80% of health data really cannot be used. And then to add to what we just said, that both providers as well as the people who are receiving the services have very little knowledge of how technical or digital platforms work. So my question to all the panelists, and you can take maybe 1 or 2 minutes to respond to this, is what needs to be done to make this better? So how can doctors understand, the value of digital platforms and invest the right kind of time and energy to be able to make that more efficient? Especially considering that most of these digital platforms, and we find very few Dr. Singhs who are there into digital as a medical professional. Usually, it's the digital doing their own bit of work and then putting that into hospitals where doctors have to use it with very little knowledge of what algorithm was there, in the initial case where it was put into place. So, given the scenario, how can the medical professionals be a part of this whole development process and educate themselves, because it's not part of the medical curriculum? Similarly, what can patient organizations like mine can do to help patients understand the value of digital and be able to ask the right questions when they are being consulted, or even when they make a choice of which digital platform to use? Right now, if you ask me, even though I am a trained medical professional, which digital platform could give me the most optimal experience? I'm not even talking of results, but most optimal experience, I have no clue. There is no way of comparing what is available out there and understand what my needs are and whether that platform will actually provide me what I'm looking for. So what can be done to make this ecosystem more usable, both from the provider side as well from the patient side? So maybe I can start with you, Sohina, and then we move to Dr. Gandhi.
Yeah, I mean, I think you raised some very important topics. Let me start, I think, with the provider side. So I think, as physicians, our responsibility is to look after patients, right? But being able to look after patients also means it's our responsibility to understand the systems that we use. We have a voice. We need to learn how to use it. It's not like we're just like, they're using. I mean, we have a voice. We should learn how to use it, and we should also speak up for what we want and what we need about the pain points, right? Because we're the ones that's actually leveraging that solution. At the same time, I would say, doctors as well need to understand the perspective also of the patient. Innovators as well need to understand all these perspectives, right? But if all of us just sit there and keep quiet and just being okay with whatever is handed to us and just being like, oh, well, what difference can I make? I mean, if we all adapt that situation, we would never have landed up with an iPhone. We wouldn't be even having this webinar on Zoom, right? So I would say it's every one of our responsibilities to dare to bring about change, right? And you can bring about change by just using your voice, right? And we all have that responsibility. So I would encourage everyone on this call to take action. We all say, oh, well, I don't know. We have access to the internet. There's a lot of information there to get going, right? When we see that there's issues and opportunities, we shouldn't go in with the approach like, woe is me, I need to wait for someone to do something. And you're right, Dr. Ratna. How does someone really evaluate these solutions? And maybe that's something that we should do on a blog. Actually, how should patients really look at what they need, right? At the same time, I would say innovators and physicians, when they're really looking at solutions that have a patient-facing application, don't stop, take your doctor hat and put it aside. Become a patient. We've all been patients. How does it make you feel? Does it truly delight you? right? Do you feel great? And by the way, who said healthcare applications need to be boring? Why do they all need to be blue and white? I am sorry. As someone that has 3 autoimmune disorders, I do not want to look at a boring app that makes me feel more ill when I look at it, right? Guys, have an imagination. We became doctors. We're creative people. We all have a creative side, right? Let's bring some life into the platform so that at least, and it can be something as super simple in the way that we communicate something to a patient. Like, we don't have to be boring about it. Your appointment is at XX. We're so excited to see you at like whatever, like let us know if we can do anything. Be friendly, be nice, be empathetic, right? I mean, what makes people great doctors is being empathetic. So bring empathy into your platforms, people. It may not have all this wonderful functionality, but just the way that we communicate and focusing on UI, my gosh, you can change a patient's whole experience. Sorry, very passionate about it. So I just wanted to share that perspective.
Thank you. And Dr. Nitiraj.
Yeah, thanks so much, Dr. Ratna. I think it just made my day, Saturday afternoon. Generally, you get into monologues and then Dr. Suina coming out firing on all cylinders. The amount of passion she exhibits. Yeah, it's interesting. So, two things that come to my mind is one is, as you rightly said, Dr. Ratna, earlier, when we are trying to improve access, we are falling into a trap where some of these digital tools might not be well curated. Now, is there an opportunity there in those sort of areas to create telementoring? There could be nursing professionals, these could be professionals who are looking at immunization and similar things, and these mentors are able to communicate with the patients sometimes in their own native language and record these symptoms, record all of the signs that they are seeing, and assist the doctor who's sitting maybe a few hundred miles away exactly to help him or her understand what is going on with the patient. So that would help us resolve a lot of the errors. And second thing is, organizations like yours who are working on patient safety. There are a lot of patients and their relatives who wish to get educated. Similarly, we have a large population of young doctors who also understand a lot of tech platforms, but they do not necessarily understand the structure in which to work about it. And by the time they graduate, postgraduate, set up their own practice and actually understand teleconsulting, maybe the tools would have changed at that point in time. So somewhere we need to have a good mix of people with semi-clinical knowledge, people with good clinical knowledge, and also kin who can actually help bridge these knowledge gaps and communication gaps. And if a patient advocacy organization like yours can help with some sort of a course where people who are interested take it up, and slowly the revolution starts. NABH, for example, NABH or any other accreditation, it started with a handful of organizations, and once it starts gaining prominence, people understand its importance, everyone starts taking shape, everyone develops certain standard protocols, and that's how we become a better society.
Thank you. And Mr. Nitin, any thoughts?
Yeah, I think again I'll resound to what Dr. Nitira said. I think starting with your organization, I think that can play a huge role, like this webinar, right? So this is the part of the patient education, how we can help them understand the places where the digitization can be useful, and the kind of protocols they should be maintaining. For example, should not be sharing the personal details, etc., even while on digital media, etc. So those are the kind of things which I think your organization can do. And from the provider's point of view, I've already highlighted number of things which can be done to make sure that how the technologies can be used to improve the patient outcomes. One thing which I think I missed highlighting is that when we talk about multiple solution available in the market, right? Uh, there are solutions which are what I'll say that they are by the books, and they are created for a particular stream. For example, maternal care, There are solutions which are for diabetology. There are solutions which are for a specific disease segment or lifestyle disease. Um, there are many solutions. I think at one point of time there will be a convergence. Well, when there will be a kind of a one app or one solution where all these different kind of things will be connected. Again, there is a way or through ABHA or ABDM to do that, but yeah, nevertheless, I think that's the future, where there will be a convergence, and all these small apps or products or platforms will start kind of exchanging data. So for patient, it becomes more simplified, right? So that's the future. Of course, it will take some time to develop such kind of a platform.
Thank you. So I'm going to ask the last question, which is going to be a little tricky. We just heard one of the participants saying, if I have an orthopedic problem and diagnosing through distance means or through digital is going to be extremely difficult. We do a lot of work on mental health, and that is again an extremely tricky area because even if the patient is sitting across the table, sometimes it's very challenging to make a diagnosis. However, given the lack of doctors and trained professionals, as you mentioned, Mr. Nitin, there's a lot of platforms that are offering services for mental health. How do we ensure that these platforms are credible, are accredited, and the data that is being collected is confidential, and because patient groups like mine also receive a lot of these calls, even though we do not have, say, a platform. But even through informal digital means, like, say, a WhatsApp group or a Facebook group, we do receive a lot of questions, especially things related to mental health, stress, anxiety, and any long-term chronic disease brings its own set of physical and mental health problems. So how do we ensure that whatever means are being used are credible and are offering the right kind of services, and that the data that is being collected is confidential, and the patient gets the best possible service that is required for their condition?
So I think first of all, if you're using any kind of a digital medium, uh, you need to refer to the terms of usage. If you are really keen of how your data is being used, so one thing is always look for there is a terms of usage. If there is no terms of usage, please do not use that platform, right? So that's the first call out. The second call out is like if that platform or that medium is not displaying the professional registration number, uh, then it can be something which we cannot trust. So I think that is something which is mandated by the government and NMC as the guideline for telemedicine. So the doctor's registration number or professional registration number has to be displayed alongside with the name when you are consulting. So that is the second thing I would say. The third thing is definitely before doing your consultation, etc. Do see the platform's credibility in terms of it's been there for some time. For example, you usually go to Amazon to buy things because you trust that platform, right? So if tomorrow is some XYZ site opens, I don't think you will buy it from there because you don't have trust. So I think those are the three things which I would say that that's how a patient can ensure trust on and platform to take telemedicine.
Thank you. I think the Gen Z would go on Insta and buy their products, not necessarily Amazon. So,
Yeah, sure.
different age groups have
Yeah.
different preferences. So, over to you, Dr. Gandhi. What would be your advice?
Interesting. I mean, I've been hearing Nitin for the past 30 minutes, and it's been very insightful. You know, I believe a comprehensive registry of the tools that are getting used across telemedicine, and also a registry of providers That is what is necessary. And somehow, beyond the boundaries of a state, beyond the boundaries of different, state medical councils, there needs to be one way, the way you've implemented a goods and services tax. I don't think a good code of conduct for telemedicine is so difficult to implement. It just needs to be done. Somebody needs to pick it up and get it done. And the moment a registry opens and there are certain stringent norms for it, I think people will make sure that they get themselves accredited. They ensure that the credentials and privileges of all these doctors are also verified, and recording of communications. I think some of the challenges that we've seen, and maybe Nitin would have more experience, but from my experiences, especially when we look at WhatsApps, when we look at some of the recorded communications, and this has been a disadvantage to the doctors, that patients have used clips of that to report to the administration, and then you find yourself in a soup that you've done everything with a good intent and only partial facts are presented, or sometimes the patient does not inform you that whether it's an emergency or not, and it cuts both ways. First of all, the doctor needs to be aware that these sort of platforms cannot be used. They do it out of goodwill, and maybe everything goes wrong, and so, you're again bearing the brunt for it. So if there are formal ways, formal tools which are accessible to people, which can work at low bandwidth also, I think that is very important, because a disruption in bandwidth can lead to even the medications or even symptoms being under or over reported. So some of these things, if they can be taken care of through formal structure, maybe we can start smaller. As you're saying, mental health helpline. You start off with only 4 or 5 centers per state, so you have very close monitoring of them. Don't spread out thin. And as you gain confidence, these then become like a train the trainer kind of concept. They are accredited or authorized to get more people accredited for mental health. The more you spread, thinner you spread without regulation, I think lapses will happen by design. Yeah.
Thank you. And I think we see more and more of that happening, because many of these go unreported, meaning, as you said, it's done in goodwill. And because WhatsApp is a easy medium, you don't have to register, you don't have to pay, so it's very, very easy. Also, now WhatsApp has channels where, you can create your own channel and start giving information to patients. So how do we regulate all of that? So thank you. And Suhina, for your last words before I wrap up.
Yeah, I think for the question that you asked, I think two things, and I'll talk about it from the data privacy, data security standpoint, because I love data. But what I would say is, I think for more often than not, I think healthcare systems, healthcare IT systems, they need to also realize, people who invent these systems need to realize, hey, actually, data security is not nice to have; it's a necessity. If you haven't actually done penetration testing, your solution really shouldn't be on the market. First and foremost, that's a responsibility of something that you should do. And, I think that anyone that's buying a solution, ask, what is your penetration testing? Have you done like black box testing, gray box, white box? I'm not going to go into what each of them are, but the white box is the most extensive. So if it is really something you're concerned about, ask the question. From the patient side, two things for privacy. So yes, terms of usage, Nathan, great stuff. Where I like to delve into is really the privacy policy that really shows you how they're actually using the data. Do they state that they're compliant? If they do, that actually should give you some vote of confidence. Read the privacy policy so that you actually understand what's happening with your data. And hey, when we're buying things, whether it's like a lipstick, foundation, or whatever else, I don't know about you, Dr. Ratna, but I look at what the reviews are, right? There's customer reviews for a reason, right? So, when you're on the App Store, hey, it's there. And you know what? Reviews of like healthcare providers and stuff like that is really very much a thing these days. I did a really wonderful study in Indonesia. People do look at that. People do use word of mouth. So once again, I think, to really find something that's a credible solution, use what works for other things, right? So yeah, I think just wanted to add that perspective too.
Thank you. It's been an absolutely wonderful discussion. And I think 1.5 hours is too small. We need a follow-up. because what I learned today has opened up a lot of avenues for many more discussions, especially from the patient perspective, because I realized I knew so little about this particular area. And if I know so little, I'm assuming that most of the people who use digital platforms would be like me. They just use it because it's available, without thinking about the data privacy, security, interoperability, etc. And as Dr. Gandhi said, we do not have a registry, neither in India or globally. I mean, nowadays you have insurance policies that actually tell you you can go overseas and get a procedure done. But then once I get the procedure in, say, the US or in Bangkok, how do I get that data back to India? We don't know. And I actually bought such a policy thinking it was a great idea, because if I had a disease that could not be cured here, I could go to the States or some other advanced country and get it cured without ever thinking how I will get the data back. So that goes to see how poorly educated we are, and we don't really think about the 360-degree perspective of how we are using data or digital platforms. So thank you all. It's been an absolute pleasure having this webinar today, and I look forward to inviting you for maybe a second round and delve a little more deeper into privacy, security, and minimizing errors, and how to make the patient feel more comfortable. Thank you. Thank you all once again.
Thanks, everyone.
Thanks.
Thank
Thanks,
you.
everyone.
Thank
Thank you.
you.
Have a great weekend. Thank you.
You
Thanks.
too.
Thanks for joining
Bye.
us.